Welcome on behalf of the Northern Arizona Family Yavapai. The discussion today is what to do in a mental health crisis. This program today focuses on providing safely navigate mental health crisis, whether you have access or private insurance. Topics include will be how the local crisis phone line utilization work and when to use them. 2, what are your rights during a crisis? And what happens when you call the crisis line? And 3, alternative options to calling the crisis line. I would like to add that Access just put out a statewide RFP relating to the crisis line. And it's an invitation to respond for people that would like to develop a statewide phone line. And so this conversation is important in that the community voice, the barriers, the challenges that we face, and what we'd like to see different are very important. And we will share this information with the bidders that will be writing up the proposals. So your participation is very, very important today. We're going to start today with Monica, who is with the Mobile Crisis Team Lead with Spectrum Healthcare. She's also kind of on live and taking calls. So if a call comes in, we're just going to switch to another speaker and then come back with her. But it looks like she's okay for right now. Go ahead, Monica.
I am good. Thank you so much. My name is Monica. I'm a BHT. I work for Spectrum Mobile Crisis Team. I am in Cottonwood. We do kind of the Cottonwood area, but Spectrum also covers the Prescott area. I am the team lead, and I am going to talk to you guys today about, what to do in a crisis. So the first question that's always asked is, how would you define a mental health crisis? So that's really what I'm going to get into. We're looking at something that's, it's a state of mind that a person's in that places them as the individual or the public in danger. A traumatic event that threatens an individual's sense of normalcy, their sense of well-being, any situation that overwhelms somebody, and they're not able to effectively utilize those coping skills that they typically use in their everyday life. Those mechanisms kind of aren't at their disposal at that moment. And basically, it's however an individual defines it for themselves. So we can't say what is a crisis for someone. If their coping mechanisms are failing, then they are in crisis. So it's something that we pay attention to. So there's 3 types. We've got the situational. Situational crisis kind of has like a sudden onset. It's unexpected. There's something going on that's got like an emergency quality to it. It's a situation where a person is okay until the situation takes place, and then all of a sudden they are in crisis. That's what we refer to as a situational crisis. There's the developmental crisis, and that is often when a person is moving from one life phase to another. It's expected. Preparation may or may not help. Sometimes because you're prepared for this life shift to take place from one phase to another, it doesn't necessarily mean, even if you prepare, that you're actually going to be prepared for it. So we take that into consideration as well. We also have a psychiatric crisis. Those typically stem from a psychiatric disorder, may result in harm to self or harm to others. There's often a lack of self-control involved. It includes and can include a behavioral component. So that's really important as well. Understanding the types of crisis is important, especially when we start to look at risk management. So we have to take a lot of factors into place. So when do we evaluate risk? So as a crisis response, we're going to evaluate risk when we meet the client, when we meet that individual. When we receive a call indicating there's any kind of mental health issues, we're going to do an evaluation after a significant trauma or loss. Bereavement is one of those things that are very unexpected. Agitated state, when a person is acting out of character, after a relapse, essentially any time we're out in the field and pretty much our gut tells us to, if that makes sense. More often than not, we do a lot of assessments. So there are things that we do in the process of a crisis response where we're going to try to build that rapport with the person. There's a lot of factors that come into place for us in crisis response once we roll into an assessment. What's very important for other people who are out in the community and recognizing what's taking place with an individual they know or an individual they may even see out in the community is approaching an individual that you feel might be in crisis. So first and foremost, your safety is paramount in these situations. It's so important when you know to the person that you're speaking with, or even if it's a stranger that you see, that you keep yourself safe. And we ask that. We ask you to kind of position yourself in a way where you're not putting yourself out on a ledge. When you're kind of recognizing whether or not you need crisis response. When it's someone that you know, it's very important if you call for crisis response that you are able to give details like, where are you located? A lot of times when you call in for crisis response, we will say, what's the address? Sometimes people feel like, oh, address, and they give a home address, when really we're looking for, where are you physically located at this moment? So it's just something to keep in mind when we ask for an address. Where are you located right now? Even if that means you're at the Maverick in Prescott Valley, we need to know that address. Phone numbers are very important. We will often ask a question like, if you know the date of birth of the person that you're calling in for. There are some questions we just would like to know to try to expedite the process. What's happening is a very important one. What's going on right now? And to be able to kind of give us the presenting facts of what's kind of happened before this and what is happening right now. So we can gauge our response. We can gauge whether or not there will be law enforcement involvement, whether or not it'll be medically necessary to get to a hospital. There's a lot of contributing factors when it comes to a crisis call.
Our next speaker is Emily Hayes, who is Director of Inpatient Services with Polara.
So this is Emmy Hayes. I am, as she said, the Director of Inpatient Services with Polara Health. I am also the Hospital Administrator for Windhaven Psychiatric Hospital. Okay, so Polara Health, if I think some of you may not be familiar, we were originally West Yavapai Guidance Clinic. So last year in June, we changed our name to Polara Health, basically as part of a, we're expanding our services out of Yavapai County. So that was part of that. Our crisis stabilization unit is located in Prescott Valley. If you're not familiar with East Eastridge Drive, it is behind the Tractor Supply and Canyon Bible Church on the highway there. So that gives you a little idea of where to find us. And this is our main phone line. It's available 24/7. After hours, it will ring into the crisis stabilization unit. There's also information about our crisis services on our website, which is listed. So our crisis stabilization unit is, it's a single point triage center. We have everybody, our staff is crisis therapists, paramedics, we have nurses, we have licensed psychiatric providers available. And it is open 24 hours a day, 7 days a week, 365 days a year. Now, to be admitted to one of either our observation unit or our bedside unit, you must be 18 years of age or older at this time. We do see children and adolescents in crisis, but at the mostly what we do at that point is we will do a crisis assessment, determine if there is need for a higher level of care, which might be an inpatient facility. And then at that point, our crisis therapists and counselors will support the family and the kids, and also get those packets sent out to try and get placement if that is what's needed. So this just kind of gives you some idea of some of the services that we have. And as Monica mentioned, a crisis is absolutely, it is something that is defined by the individual in crisis. But some of the things that occur that might lead to an admission to our unit, some of the suicidality, the self-harming. We do a lot of detox services for people that are looking to get into a residential treatment center and just need an acute withdrawal period. We do the observation and monitoring, so that's a really nice service that we have for the community. And sometimes people will start in the chairs, which are up to 24 hours, and then we will transition to a higher level of care. So it's a nice opportunity to allow somebody who's not sure about going into a hospital per se. It gives a point where they can be monitored, evaluated, observed, and get some care from peer supports and different mental health providers before that next level of care. So these are just some pictures. When you walk into our crisis stabilization unit, we have this front desk area that is staffed 24/7 with our eligibility and enrollment team. We have actually a crisis navigator that we're hiring that's going to help with next steps post-crisis. You know, the crisis, a lot of times there's a lot of upfront services, and then what happens after I'm out of that initial crisis. Sometimes it's hard to get those next services in place. So that's something we're looking at. That middle picture it shows our observation chairs, and they're spaced out. We actually have 10 chairs, but we had reduced to 8 due to the COVID criteria. So they recline, they're very comfortable. And then the picture on this right side is our group area. There's a nursing station in between. So there's a nursing station with observation on both sides. And then those doors lead into bedrooms. And we have 8 beds on the unit, doubles and some singles available. So this is just kind of again, our contact information. So it's included here in the presentation later. There's a couple things. So for folks that might be coming in and would be admitted to either our chair services or our bed services, there's a couple criteria that are just really important because we are freestanding facilities and we're not attached to a medical unit. We need individuals to be independent with their activities of daily living, at least to a point where we can support. So mostly independent with those able to either walk or transfer from a wheelchair or have some kind of an ambulatory device that helps assist, but they're mostly independent. You do not need to have insurance. That's a big one. People don't understand that. There are crisis funds that will cover those services. And right now we are requiring a COVID-19 test if you are going to be admitted to either our beds or our chairs. So I think that gives you a little bit of an overview of the crisis stabilization unit.
Thank you, Emmy. I know there's going to be a lot of questions from
Yeah.
both presentations. I can see people taking notes as I am doing. So the third speaker is Michael Van Story. Anyway, Michael is the Wormline Program Manager for Hope Incorporated, which is mainly in the Tucson area.
My name is Michael Van Story, and I am the program manager for the Wormline. The Wormline is one of several community outreach programs at Hope Incorporated, and we're currently under the direction of Senior Director Richard Sandoval. The other programs include the PAC, which is the Peer Aftercare Team, the Opioid Outreach Team, and Criminal Diversion Program. Hope is a specialty provider and offers individual, group counseling, case management, and peer support services to enhance or support a member who's affiliated with a health home and needs extra services. The Wormline, unlike the two other presentations, the Wormline is a confidential non-emergency phone line, and we provide services in 8 counties: Cochise, Graham, Greenlee, La Paz, Pima, Pinal, and Santa Cruz and Yuma counties. The service is free, and it allows callers who are or who may not be affiliated with a health home and who do not have access, may have private insurance, or just choose to remain anonymous. It allows them access to certified peer recovery specialists who have firsthand living experience with mental health or substance use issues. We currently have 8 operators, and we're in the process of onboarding 2 additional operators. We're currently averaging around 1,400 to 1,500 calls per week. One of the things that's unique about the Wormline is we're funded through what's called a block purchase agreement from Access. And this block purchase agreement allows us to provide services, like I said, for people that do not have insurance, may not be affiliated with a health home, and who simply just choose to remain anonymous. Callers are allowed to call us 5 times per day. The calls are 15 minutes each and 10 minutes each after 4 p.m. And we're open 365 days a year. And on holidays, 8 a.m. till 10 p.m. And then on holidays, we're open 8 a.m. to 6 p.m. We are also now available in Spanish to the Spanish-speaking community. And we currently have an operator in Nogales, and we're onboarding our operator in Yuma and Sierra Vista. The Spanish Wormline is accessible through the normal Wormline number, and then callers will choose an option for Spanish. Our Spanish Wormline is currently only open from 8 a.m. until 4 p.m. Monday through Friday. And as we build up callers and onboard more staff, our goal is to make that available the same times as the normal Wormline, the English Wormline, I'm sorry. Our operators provide support through active and reflective listening, non-judgmental and an empathetic manner, just to help callers through their normal routine of their recovery during the day. We talk about a great deal of things from, issues with their health home, issues with their medications, issues with rent and food, and just anything that callers need support for in general. Through daily encounters with our callers and meeting them where they're at the moment, we build strong, trusting relationships and offer callers a safe and appropriate place to process thoughts and experiences regarding their daily lives. The Wormline also assists callers in connecting or reconnecting with behavioral health services, self-advocation, and we provide, like I said, valuable resources for food, shelter, support groups, and addiction counseling or education. One of the things that I'm proud to do as the program manager of the Wormline, or to be a part of, is working in unison with the Crisis Response Center, Crisis Response Network, and connecting those people who call us to the appropriate services, or helping the Crisis Response Center give frequent callers with non-emergency needs an appropriate place to call as well. We're also working with, currently working with a program entitled 911 Familiar Faces. And this is along the same lines of helping reduce frequent callers of emergency 911 to connecting them with resources and services in the community, and also providing them an appropriate place to call daily for support. We're also actively involved in the community, and we work with local workforce development programs such as NAMI, the University of Arizona Workforce Development Program, and the Coyote Task Force, in actively recruiting newly certified peer recovery support specialists for our volunteer internship program. The volunteer program is 180 hours long. During the internship, individuals can learn valuable skills to help them move forward in the behavioral health field in whichever direction they choose. When they successfully complete the program, they get a certificate of completion, professional reference. And if we have any openings at Hope, we encourage them to apply for anything they may be qualified for. Thank you.
Michael, that was excellent. And I would also like to share with everyone that Hope is maneuvering. They were written into the contract for Care First, and they will be moving up to Northern Arizona. So I think we're going to see a little bit more, Michael, in the next months and years. So that was very, very nice. So what kind of questions do you guys have? Don?
Yeah, just a couple things. Being an individual that's experienced crisis and is a peer support, several things came up with the first two presentations that I'd like to talk about. One is with Monica being in the crisis team. First and foremost to me, when I was in crisis, I did not know that I was in crisis. Okay. So when I hear, it wasn't until I'll go on camera. So just like everybody else, fair game, I guess. So I think from a perspective of an individual with lived experience, it's often difficult until possibly the crisis hits a certain point for us to kind of look in that mirror and assess, where we are. And one thing that I've seen occur over and over and over again, and I've been doing this a really long time, is the questions that are asked that individuals are able to answer. And oftentimes I see the crisis teams leaving based on those individuals' answers. And I am a staunch advocate for people's rights. So I get the tightrope that you're walking with not wanting to, step on somebody's rights. But again, there is that place where when you're in crisis, you can't really see that you're in crisis. So what valuation is put on the loved ones, input during that very initial visit, or on friends that may be there? If it wasn't for my friend Kathy Batcher, I wouldn't have gotten into help when I had my crisis. That's number one. Food for thought. A larger issue for someone like me, as a family member for an individual that has unique challenges is that oftentimes I have had to wait upward of 8 hours for any type of crisis intervention due to my daughter's specific needs. And so she's deaf, and there are not interpreters that are readily available. And you can imagine if you're a family member and your loved one's in crisis, you are probably not, the individual may not want that family member who signs fluently to interpret for them. So in both cases, I've almost lost my daughter. She's almost passed due to not having the appropriate resources available. So, and I'm going to go.
I can
Oh.
absolutely speak to both of those things.
Okay, so
absolutely.
Just in addition, I just want to say there are said that there are resources like iPads with VIR attached. Those are not functioning. And I actually live in Maricopa County, where, you know, the great state of Maricopa, right? Everything is supposed to be here, but it's not functioning. And in my opinion, it's a broken system for these type of individuals. So that's so far some of the comments that I have. Thanks, Monica. I appreciate you being brave and diving in there.
I will absolutely dive in. Okay, so there are many levels to what you said. You said the word daughter, and a lot of times when it comes to anyone who's a juvenile under the age of 18, we have a lot more room to navigate. Now, I don't know.
I just want to interrupt really quick. She is. I hopefully I look younger than I am, but my daughter is 35.
Oh my gosh, I would never have guessed in 1,000 years. Okay, so adult children, that's a little bit different. So let's touch into a very sensitive spot, which is the Title 36 process. And that is when someone who's in crisis basically either says, no, thank you, I don't want to speak to anyone in crisis today, or they give those answers that just basically mean their life is just fine and everything's cool. It does put us in a spot. And you said that when you were speaking, it's an interesting spot for a crisis response specialist to be in, because we have to be able to see what's happening before we can even put in an evaluation for a further assessment through a Title 36 process. Title 36 process is involuntary. So we need to be able to tell a judge why we feel that we can take this person's, not take this person's rights, but take them to a spot where they need further evaluation. We need to be able to articulate that. And if we're not given much information and we don't see it ourselves, that puts us in a tricky spot, especially when we're standing in front of a judge. So a very good piece of information that I would love for you to have is that anyone of sound mind can fill out a title. The Title 36 is an application. So it's just an application saying, hey, we would like this person to be further evaluated for possible involuntary placement. So that's the cool part. So let's say crisis comes in, they do an assessment, and the person we're talking to gives zero indication of anything actually being wrong. At that point, family members, friends, anyone of sound mind can say, no, this is what I saw, this is what they said to me, they're not being truthful. And we can assist in you filling out that Title 36 paperwork, and we will take you through the whole process, okay? So that does happen, and I'm very, very sorry that that happened to you. It's unfortunate, but it does happen in this world where people don't believe they're in crisis, and they sometimes kind of sugarcoat all of their answers to be nice and padded. And it looks almost as if they are not at a high acuity when family members and friends see the higher acuity. That was the first portion. The second portion is guardianship. When someone has guardianship, that kind of changes it to where they can make the decisions and we don't have to go into the Title 36 process. So for people who have loved ones that are at a level to where they're permanently or acutely disabled, it's not a bad idea to go through the courts to get that guardianship, because then you can make those decisions on behalf of your family or friends. When it's a teenager, it's important to understand that parents kind of get to make the decisions when it comes to teens and children, anyone under the age of 18. So we would never, ever, ever do a Title 36 on someone under the age of 18, because they have that person, that guardian, that's going to make the decisions for them, whether they say yes or no. Another portion of what you said, there were a couple, so I'm hopefully hitting all of them, is it is very tricky for us to walk into a situation and have the client say, I don't wish to speak to you. It does happen, and we try. We delicately, gently, compassionately try to speak. But if they don't want to speak to us and they don't have a guardian and we don't have any reason to put in a title, it's not something that we can force someone to talk to us if they don't want to. We try though. Did I hit everything? I feel like I hit everything, but I might have missed something.
Yeah, I want to give room to others too, because when you go through and you navigate the crisis system, whether it's for yourself or others, you have this firsthand lived experience, like Michael was referring to with our peer supports. So there's such a depth of need and understanding and nuances that occur depending on who responds. But I'll put myself on mute and wait till others ask, and then I can bring myself back around.
So Don, I think you raised some very, and then we'll get to you, Rose, some very good concerns. Monica, these were some good suggestions, but I would like to ask Michael, as far as recovery, to put a person into a situation of being Title 36 or guardianship, I mean, it does something to us. It's hurtful. And I've been in those situations as a peer. And so, Michael, I'd like maybe you to elongate your answer to maybe illustrate how peer support could be a little bit more active in getting information, filling in that feedback loop, like crisis. I know you refer to crisis, but how much do they refer to peers and to hope?
Yes, good questions. So that's one of the places where we, the Warm Line, hope to bridge that gap. A lot of times folks will call us not knowing they're in a crisis. And I think the peer support element of it, in sharing lived experience, can help assess someone, help someone assess their own situation better. And we can also point those individuals in the right direction, if they are in crisis. But help kind of assess the situation more, and provide that person with maybe resources and coping skills that may help them instead. Does that make sense?
Yes, thank you. I think that we could really utilize peer and family support to a much, much bigger degree, especially as a prevention to having a crisis event down the road. So Emmy, you had a comment, and then Rose. I'm sorry, Emmy.
Yeah.
It's okay.
I just wanted to answer a couple of the things that Dawn brought up, and I want to mention we, in addition to our staff, we have peer supports on site at the Crisis Stabilization Unit, because we do recognize how effective they are in working with people who are experiencing a crisis. It's been wonderful, their ability to engage perhaps somebody who's feeling very fearful. I think that's one of the biggest things. Another thing that we have CIRICOM services for interpretation. We've used that for the deaf community. We also have, actually, we're fortunate enough to have 2 of our crisis therapists are bilingual in Spanish. So that's been amazing. So those are a couple things that we have available to assist somebody who is walking in to the crisis stabilization unit. So we do take folks, there's am I talking about Polara peer staff? Yes, we have peer supports that are on staff with Polara Health, and 3 of them are assigned out of the CSU. So they're there pretty much. I think right now we have a peer there 6 days a week. We're working on getting Sunday covered. So from 7 until about 11 o'clock at night, because you know, a lot of times people are walking in the evenings or later on in the night. So I think those were the things I wanted to bring up. Also, if you have a loved one, because guardianship and Title 36 are, you know, it's an issue where you've now kind of infringed on somebody's rights in some way. I don't want to speak poorly of it, because there are times when we have to go that route. But another option is a mental health power of attorney. And I'm finding that a lot of people are not aware that that's something that's out there. It's so important, especially as we all age, because there are times where some of the most difficult crises that we encounter are when our loved ones are having a developmental crisis, like we're seeing early onset dementia, something like that, where if you have a mental health power of attorney and that person does not have the ability to, they do not have capacity. And that has to be evaluated by 2 providers. I believe one has to be a medical provider, one should be a psychiatric provider, but you have to have 2 providers that are basically saying this person is not able, they do not have capacity for informed consent. So at that point, it allows a loved one to step in simply while the crisis is happening. And sometimes that crisis can be ongoing, or it's just that they're having a psychiatric crisis and then now they get stabilized. And the minute they're able to have that capacity back, it's back in their hands. So that's just another option.
Just real quick, Emmy, with regard to that, because that's a dangerous slippery slope for our community. Just wondering who decides when they have capacity again, because if it's a family member that's initiating that, then is it out of the hand? Like, who makes that decision?
It must be made by a medical provider. 2 medical providers have to agree that that person does not have capacity to consent. So a family member can bring them in and they can say, I have mental health power of attorney. However, until 2 providers have said, okay, well, you have this, but you know what? Your loved one is making good decisions, or they're able, and that's a funny word too, good decisions. As long as we can say that they understand. And so it may be that I understand that by not consenting to a procedure, for example, I understand the outcome may be that if it's a medical procedure that I may not live. As long as I can state that I understand that and the doctor is able to say, yep, they understand that, that's a choice. So you cannot take that person's capacity away. So these are things where I think if more people understood the mental health power of attorney, it's a pretty safe option that I just would love people to look into a little further. There's some great information out there on the websites for the county and the government. I'll see if I can find that and put it in the chat.
So this is exactly why we're having this conversation, because, you know, we all want the same thing. We all mean the best. Providers, their hands are tied in many ways, and so are the parents, and so and peers. And so having these conversations, we can work together and maybe ameliorate some of the stress of these situations. So Rose, do you have some people that you want to Go ahead.
Oh, yes, I have a question for Monica. When a crisis call comes in from a family member and it's a fairly dangerous situation, either to self or to others, when does the police intervene? Should a family member call both the crisis line and the police so that they can both work together on this crisis? Or is it better just to call the police immediately and then also, or will the police contact the spectrum through the crisis line? Which way does it work?
Well, sometimes when you are certain that there is an element of danger to others or danger to self involved, sometimes you can just speed that process right along, start with law enforcement. Our relationship with law enforcement is stellar. We have a very good relationship with them. So when you contact law enforcement, you say, this is what's going on. We also want to reach out to Spectrum. The dispatcher should be able to streamline that process for you. When someone you're with is in crisis, it's almost like a secondary crisis takes place. Even though you are not the person in crisis, you are handling big feelings. So we want to ensure that safety is in there and that help is on the way. So when you know that there's an element of safety that you need to consider, starting with law enforcement and letting them know to get a hold of Spectrum works very, very well because we can come together. If you are in a spot where you're not quite sure, that's when you make the call, you say, this is what's going on. What do you think? And crisis can also do that on everyone's behalf. We have been trained to recognize when we need that additional support. Okay, so you can start with us if you're not sure, and we kind of navigate through those waters in every situation, every call that we get. And also we're 24/7, so our crisis line is available weekends, holidays, all the time. So that means, for a good chunk of time, I was working nights, and sometimes a call at 3 o'clock in the morning that was just a little bit like, I'm not sure, I would oftentimes get back up just because it's 3 a.m. and I'm going to someone's house. So I wanted to put that part in there as well, is sometimes, even though that acuity doesn't quite feel like, well, does law enforcement really have to be involved here? Sometimes there are other factors involved to where law enforcement may be included.
Last summer, before Polara was Polara, they were still West Yavapai, I took my son Nick, my adult son Nick, to the CSU because he was having really bad anxiety and wanted to go to the hospital, and I wanted to avoid that. So I tried CSU. When we got there, it was nighttime, and they did not have any space available. So they said they were going to send him to Windhaven, and we want to avoid Windhaven if we can. So we balked at that. Thing is, I'm Nick's legal guardian, but West Yavapai could not confirm that because Nick is a patient, a client with Southwest Behavioral. And in the anxiety of the moment, I did not think to bring my legal guardian papers with me. So they would not listen to me. They felt I couldn't represent him because I couldn't prove I was legal guardian. One other point I wanted to make is if you're going to bring somebody to the CSU and they figure they might be there 24 hours or go somewhere else, bring the meds with them. Bring the meds with him. Because I did that, but once again, I wasn't legal guardian. I mean, I couldn't prove that I was legal guardian. So they were going to have to do their own evaluation of what meds he was taking and all that and what they would give him. Just some points there.
So thank you, Bruce. So I'll get to Dawn in just a minute. You can just feel her intensity. So I'd just like to ask a question to Michael. So when the language that's used in a lot of the reports, when you bring a person in, they're assessed, And a lot of the language is legal language and rather than behavioral health language. And there's a concern in our community that this sets the person up for prosecution down the road. And it's also kind of, it's not really recovery orientated. And I'd like Don to elaborate a little bit about this. And you and Michael have a kind of a back and forth. Can you do that? Can you do that, Don?
Yeah, I can do that. Hey, Michael. I'll save my other point for after. So everybody knows, I'm with the Office of Individual and Family Affairs. I see some of my counterparts on this call too. So not only are we individuals with lived experience, and family members, but we also meet with members and family members every day of the year. So my perspective is varied, is what I'm trying to say. So there has been legal language used. An example with ER reports when crisis made transport to ER, or, I've seen the records and they may say things like reason for visit, violent, aggressive behavior. Okay, and so I'm concerned with that type of language, because what ends up happening is that follows the individual through. Really, the reason for the visit is a mental health crisis, right? And so we don't see that language in some of the reports that are populated. And these individuals, if that record is pulled and they have a future mental health crisis, we see aggressive and violent behavior following them. Then the crisis team, and Monica, you could correct me if I don't know, I'm not speaking for you as an individual, but what's also occurs when that language is revisited in the future is that most oftentimes crisis will not approach the individual without law enforcement first coming onto the scene for safety reasons, which makes sense, but really the language is what's concerning, because if the individual is in a mental health crisis, I would like to see that recovery-based language used, and whether it be the crisis team, which most often, I'm referring to a hospital or other professionals that may come on the scene. But Michael, we know that when we get into those type of terms as individuals with lived experience, that terminology and those records follow individuals into the future and can hinder their progress in receiving care or what type of care they get. And so I'm wondering, Michael, if you have any comments with regard to that and what your thoughts are about that, how that can damage an individual's ability to receive services and what type of services they start receiving.
Well, I would definitely agree that the labels follow, and it not only hinders, it not only affects the way the next person deals with that person, without fully assessing the current situation. It also makes that person reluctant to reach out for crisis services when they really need again. We get a lot of callers who say they're not comfortable speaking with the crisis line because of the vernacular and the they feel, these are their words, the automatic assumption that here we go again with the same type of thing. Now the other side of that is that we have a lot of folks who call the crisis line with non-emergency issues as well. So it's kind of a double-edged sword, but I would definitely agree that the record follows, and it not only makes it difficult for the next person to work with that person fairly, it also makes the member or person reluctant to reach out for fear of, of that label or record. I hope that made sense.
Yes, it does. And that's really for the professionals that are on this meeting. The reason that I think Kathy brought this up is that we already have a struggle within this population of reaching out to crisis. Our family members are put into a position where when they reach out and this type of behavior is occurring, they want to support their loved one to get the care and concern, but they also are very, very aware if there is a history of this language in documentation rather than recovery-based, person-centered language being utilized, then their loved one risks justice
Yeah.
involvement. And so, part of me wanting to get solution based and knowing how hard the work is wondering if there needs to be, some front end education with maybe emergency rooms, that are engaging with crisis teams and crisis individuals. If there is a medical component that occurs where the individual is transferred to an ER, I'm just wondering if the crisis teams and Monica, your team works with individuals to educate on that type of language. So that's, I think, why Kathy brought that up.
I just wanted to add that I think some of the disconnect as well is kind of like Bruce was explaining in his situation. A lot of times when people are in crisis, they don't have all the answers. They don't articulate what's going on with them very well. And I think that, record as you're referring to, Don, kind of gives them that slap in the hand back before they can really gather their senses to explain their situation correctly. I mean, I know when I've been in a crisis, I couldn't remember my paperwork or, maybe even my driver's license number. It's just, so that makes people reluctant to reach out as well, is that experience with, being asked if they're sure they're in a crisis or something like that. Not in those exact words. I'm just saying, to have that experience when they do call the crisis centers.
So Monica and Emmy, you look like you'd like to respond.
Yeah, it's just, it's an interesting and much needed conversation. I can only speak as to how Spectrum crisis response moves through these types of situations. We ultimately, if we have had contact with a client before, we will look at what's happened in the past. Ours is a summary. So it's more of a, we go straight to what the summary of the last situation was. So those labels aren't necessarily tags. They're just a summary of what the situation was prior. So, I mean, this is a much needed conversation to have, absolutely, as far as that person-centered language that everyone is very, very interested in. We approach every crisis response as if it's a new day. Trust the universe, but lock your doors. We're going to trust that this is a new experience. This is a new time. We'll see what happens. But at the same time, we also have to keep ourselves safe. It can be a tricky situation. It's a balance. But I can only speak for Spectrum when I say, when we go into past assessments, we're looking at summaries. I don't know if that helps at all. It's navigating tricky waters here.
But I have to laugh because it was 15 years ago then that, we didn't even have a place where the police could bring people for a crisis. We take them to emergency rooms, and basically what we're doing is fine tuning. It's very, very important but we're really fine tuning the system so it'll work, and we're all working together on that. So, Emmy, do you want to share any, a little bit?
Well, I put a couple things in the chat, but it is absolutely an ongoing process. We work regularly with law enforcement agencies. We participate in their crisis intervention training. We are also working with our own staff to get everybody, brought up into kind of the now and trying to use more of that person in recovery language. We're working very hard to change the language to guests. These are guests coming into the crisis stabilization unit for services, and moving away from things like patient or client. You're a guest. So it is an ongoing process. I mentioned that our peer manager, some of you I know many of you know Katie Welty. She is an advocate working very hard to kind of battle against that stigma that's out there. And it touches my heart. I'm not a certified peer, but I have certainly dealt with a lot of these issues in my own family, which is what brought me into this. So it's a very passionate place for me as well. So.
Well, thank you, Emmy. We have Kellyanne. Where did she go? She's up there. Oh, there you are, Kellyanne.
Hello, I'm Kellyanne Smith. I'm the Northern Arizona liaison for Solari, and I just wanted to piggyback off of what Monica had just mentioned with regard to crisis response. Through the crisis line with Solari, our goal is really to ensure that individuals who are calling in are community stabilized. So that means that we'll work with the caller to identify the reason for call, various risk factors, and to better understand the history of the caller and the caller's needs in the moment. So should a caller call in, our staff are able to discuss with them what the next steps would be, and some of the items that they might want to have on hand when and if a crisis specialist is needed to arrive on scene through a mobile team. So if you were to call the Solari crisis line, it is not necessarily going to be, let's take your address and we'll send out a crisis team through Spectrum or Teros, but we'll work with you to identify how we can move forward, answer any questions that you have. Obviously, if it is a situation where someone is in danger to themselves or others, we would add on a law enforcement team, and we would try to get that call handled as quickly as possible to move through the next steps. But we do want to ensure that the caller fully understands and has the questions that they have answered.
Okay, thank you, Kellyanne. We appreciate that information. Carol, you had a question you wrote in chat. Would you like to verbalize that?
Oh, I put my question on the post, and Michael, thanks for answering my concern here. But yeah, one of our challenges was taking our son to the crisis stabilization in Prescott Valley and being turned away due to not having access, but yet telling us all the programs that our son is eligible for. But then going to the desk and finding out, oh no, oh forget that. Here's some financial paperwork to help you with. And it's like, no, we just need help, and just no referrals after that. So that's the challenge as a parent, and I think other parents might face in our rural areas.
Yeah, they're very, very unique. We're going to get Dawn, and then I'm just going to warn Ralph, I'm headed in your direction.
Thanks, Kathy. So just another point that is a huge missing component. So for Kellyanne and Monica, who are out there and dealing with the crisis calls, it's the directly after. So in situations that we face, when a crisis team comes out, if they are actually not taking that individual into an inpatient facility, what currently occurs is maybe a possible like, what do you call it? Like a card that has the crisis agency's name on it. And then also on the opposite side, it'll have a few agencies that have what they call peer navigators, or, so the missing component is that connection to those community resources that are available. The peer support agencies, we know since the 90s that peer supports enhance and create longevity in an individual's wellness journey. And so, rather than a card referring a member to an agency specifically that the crisis team is connected with, like let's say La Frontera or whoever it is, okay? We have to be able to have resources that include the local peer and family run agencies that are available for that follow-up support within like 24 hours of care, because that essential component of having a credentialed staff who is outside of an agency or a hospital setting is the one that's going to directly affect the longevity of the recovery, as well as the community supports that need to wrap around that individual. And so that is occurring across the state, whether you're in northern Arizona, southern Arizona, or central Arizona. That missing component is directly affecting the members that we serve.
I hear you. I would love to show you what Spectrum does. I can't speak for all crisis response, but I can certainly show you what Spectrum does. We have what we call a safety plan. And in this plan, we handwrite out right there on scene, and it's got the carbon copy on the back. So we take one copy, the other copy goes with the client. And this is going to outline phone numbers. This is going to outline the safety precautions taken, and safety precautions can change from crisis to crisis, but some of these things is basically you're getting an initial from the client that's stating, yes, I do agree to take my prescription medication as prescribed, or yes, I do agree to avoid alcohol and other substances. Yes, I do agree to reach out for 24/7 support, those WRAP services. It also has a line where we talk about coping skills. And sometimes after crisis, once that person begins to regulate, we can start to openly discuss what are some things that you do that can maybe help ease anxiety. What are some of the coping skills that you like? Because sometimes having this piece of paper posted on your refrigerator, in those moments, you can look back and go, oh yeah, I remember I talked about that. I'm going to listen to drums. That's what I'm going to do. I'm going to play my drums. And it's pre-established. And then we also have the supports and appointments where we discuss what supports are available, what appointments, those WRAP services, and then finally the other plans. And that's where we discuss what else is going to happen. Sometimes that other plan is quite simply, I'm going to eat a meal. Because a lot of times when people get in a space where that self-care kind of gets sidetracked, we can remind them, remember when all this is said and done, what some of your other plans were and who you were going to reach out to, and how you had discussed that you were willing to join a group for services. We put it all together, and then it's signed by not only the crisis response specialist, but it's also signed by the client or even the guardian in cases of guardians and children. It's something that's important for that
Huge.
buy-in, for someone to actually sign a piece of paper that says, yes, we talked about this and I'm going to try this. That's what we do. I can't
So,
necessarily.
so I would just like to give a shout out to Will, who is on this call. And Candy and I have actually witnessed this, where he did a follow-up with an individual that we could have easily lost. And Will has been visiting this individual on a weekly basis, and it's changed their life. But he has been helping the individual, just like with this list of things, Monica, that you outlined. So he won't show his face. Oh, he did. There he is. So yay, Will. We've gotten some excellent results with Will, and we expect to see a lot more. Tracy, you had a question?
Yeah, I was just going to comment and kind of dovetail off what Monica just said. Yeah, safety plans are definitely the standard model of care. And I was just going to kind of dovetail off what she said. Teros does the same thing. So we have a segment on our safety plan that talks about their strengths, their weaknesses, their coping skills, and then who they would contact in a crisis. Because like somebody, I think Michael pointed out, in a crisis, our minds don't work very well. We can't remember things. We can't remember those phone numbers that we have on the top of our heads. We freeze. And so that safety plan, having that carbon copy, I recommend to clients to carry that with you. It's your lifeline. It reminds you, you do have strengths, you do have coping skills, and those phone numbers, your number to your clinic, your number to your case manager, your number to your therapist, your number to your mom, your dad, your best friend is right there with you. And then something else that we do is we do a 24-hour follow-up. So when we're with that client, we encourage them, when was the last time you called your behavioral health home? You know what, let's make that call right now. And then when we're with them in that 24-hour follow-up, hey, did you hear back from your clinic? You didn't? Let's make that call again. We're doing that right now because we know that the clinics are busy. They're understaffed, and let's make that call with them. So we know, and we're putting in our documentation, we made that second call. We made that first call with them. So that call is made and we have the documentation that it's been made. And then we're sending that assessment over to the behavioral health home as well. So we know there's that continuity of care and we know there's that coordination of care. So that, there's that wraparound service. We're also giving referrals specific and customized to the person. What do they need? Do they need help with meditation? Do they need, breathing and grounding techniques? Do they need special help with boundaries? Do they maybe need, the recent meeting list, online meetings, in-person meetings, that kind of thing? Did they just lose somebody to COVID? Do they need listings of maybe where the grief, their grief counseling or grief meetings? So we really try and tailor it to that particular person in crisis.
Yeah.
Thank you, Tracy. Hope everyone is thinking about Ukraine. And, as I mentioned this is adding a lot of stress to our community. It's just one more stressor for parent family members, for all of us. And so our prayers are in that situation. Go ahead, George.
Well, Kathy, thank you very much. The books in the shrine help me be calmer as I answer this question. So if you don't recognize me, my name is George Gallagher, and at this time, I'm celebrating 50 years of living with depression. And it is through many experiences with the Maricopa County Crisis Line that I am still alive. So I'm not an ungrateful wretch. However, for all of Arizona, something that's changed is that I heard the safety plan. I'm delighted. But what needs to happen is you need to contact that person's team automatically by computer, so that if I call crisis tonight, my case manager will know about it tomorrow. Now, what does happen is it goes to the clinical manager of the sites. That was the last thing that I was told. But that's not any good because I'd like to make an announcement here that I'm not going to file a complaint, but I learned that at my site, which takes care of about 1,300 to 1,500 people, 5 teams, there are an average of 2 case managers per team. Sometimes they've bumped it up to 2.5. But a full team would have 6 case managers and 3 specialists or 9 folks. So I just went 4 months without contact with the system. And I called in, but what I was told, and here's the deal, they no longer are able to return a call within 24 hours. That the advice from the case managers, after waiting 2.5 hours in the lobby to speak with one, is do not leave a voicemail message. Don't leave voicemail with the blue dot. Don't leave voicemail with me, because I'm part-time. I have 160 clients or guests. So
So
forgive me
George,
for, so there you go.
George, you and I have known each other for a long time. And this is a very stressful situation. It's brought on by COVID, and it stressed you and me and, the people that work at the clinic. I think this is something we should take to the advocacy meeting tomorrow. We need to share this. Maybe you could help step in and reach out to other people that can't get in. And I think there's a role for you if you can think about it. It's very sad because, you're doing great, but there's many people that aren't. And so I'm just going to challenge you at this point to maybe think of some ways that the community could be a little bit more helpful. And you'll be at the advocacy meeting tomorrow. So I'll talk to you
Sure.
about it. Okay.
Thank you.
Yeah. And thanks for all that you've done for our community, George. I met George probably 20 years ago, and he taught me about advocacy. I never knew. Some of the things that I learned because of George is just phenomenal. So I'm going to turn it over to Ralph. You have written into the whatever it's called, the chat. What's the purpose of this call since we have a new statewide phone number coming in?
Yeah, I was just reflecting as I was listening to this conversation that we are talking, all the people are talking very knowledgeably about what the system is, whether it's Monica as a part of the system or Dawn as part of the system on the other side. And yet it seems like if we are going to get to the 988 system, which is allegedly what our country is headed for in July, and our state is obviously a part of our country. It seems like we should be starting with the end in mind and thinking about how do we, not just what do we do and how good we are in various ways, but what are the deltas between where we are with our system and where we need to be in this situation of a 988 number instead of just a 911 number available to us. And those of us that are family members in the community of mental health look forward to the possibility that there's an alternate place to go for our loved ones in a crisis situation, and that's the 988 system, where somebody is coming along with EMT without the officers of public safety and dealing with the crisis and working to get people stabilized and into the stable situation that so many of you down in the great state of Maricopa and Yavapai County are talking about, the systems you have. We don't have that kind of a situation in Northeast Arizona to start with, but that's, I don't know if I make any sense, Kelly.
Okay, so thank you, Ralph. I'm going to put up, can you do that?
Yeah, I was going to do this.
Okay, so the Arizona Parent Family Coalition is having their general meeting March 8th. from 12 to 1:30. And I think, Ralph, you came on late, but on February 18th, Mercy Care, Care First, and Arizona Complete Health issued an invitation to respond to select and procure a statewide crisis telephone line provider. Their plan is to jointly select a single statewide provider by 4/1/22 with intent to begin operations. So as a community, the point of the Arizona Parent Family Coalition meeting is to talk about the crisis system, what can improve, and what are the growth opportunities. And so I think you're exactly right at some levels. I don't know, it seems like it takes a higher level person to really answer the questions about the 988 system and how the Arizona system will interface with that. I think there's a lot of questions. Can anyone answer that at this point? No? Okay. So
Yeah.
this is a step in that direction, Ralph. So I mean, I hope that we have more information by February or March 8th to answer some of your concerns. So we have Carmen that has a question.
Hi there, my name is Carmen Griffin, and I just want to say I'm really glad to be on this conversation. I had an episode of bipolar mania and mixed episode when I was 40, which was like over 15 years ago, and there wasn't any help available at that time for people in crisis. My mom flew out here from California to try to get me help, and we had to go through the hospital, and it was just really pretty traumatic. And so I just want to applaud everybody for all the work you've done in Yavapai County and other counties to provide service to people who are suffering. The other thing I had was that I called Spectrum recently on the trying to get through to the crisis line. You call the main line, and it doesn't go. You don't get a first thing to crisis. It goes to other things first.
Actually,
And
we
that-
just changed it. We just
Okay.
changed it. So I'm so
Oh,
sorry to
great.
interrupt you, but it's very
No.
exciting news. It just
It
happened
is.
a couple days ago, and now you can dial 2 and you come straight to us.
Okay, thank you. That's
Yeah.
wonderful.
I didn't mean to cut you off, but I
No,
just
no,
wanted
that's
to let
great.
you know we totally made the change. So it's
Okay.
exciting news.
Thanks, Monica.
No problem.
So that raises another question. I mean, first of all, Carmen, thank you for sharing, because it's good to hear that we have done a good job. I mean, I think we hear complaints a lot of times. But the other question is, it seems to me that there's a number of crisis lines. So how do we know which crisis line to call?
I'll step in there. Bree Barrios, who is the crisis coordinator with Health Choice. It looks like she stepped off of the call. This would be a really good question for her. So in Arizona, we have the REBAs, the Regional Behavioral Health Authorities. They administer crisis services, and it is trickled down to a variety of agencies. In Yavapai County, there is the crisis line, Solari us. Also operating is Spectrum. They have crisis mobile teams. And then we have Teros, who has crisis mobile teams. Solari has the contract with Health Choice to be the crisis provider for Yavapai County. However, as Monica indicated, you're more than welcome to call Spectrum. Monica, I don't want to step on your shoes, so you can hop in from there.
Well, but Kellyanne, what I would like to know is, how do you decide when if people call Spectrum or Solari, and then do you decide who sends out a crisis team?
We do not decide necessarily. Again, we have a contract with Health Choice, and Health Choice has the contract with Spectrum and with Teros. And their contract is that we would send crisis mobile teams through Spectrum for East Yavapai, which would be the Verde Valley, and Teros for West Yavapai, which would be the Prescott and other areas in the western Verde Valley areas.
Oh,
Okay,
how I wish Bree was on this call right now.
Sorry.
I said, how I wish Bree was on this call right now, because this is a big point of contention and a big point of confusion, I think, for Yavapai County.
How is it a point of confusion?
Well, I think Kellyanne can speak to this too. Taros holds the contract for Western Yavapai County, from what I understand. Is that correct, Kellyanne?
Yes, it is.
Okay,
I
So,
think the
Emmy?
biggest thing I would say is it doesn't, honestly, if you're in crisis, call one of them.
Yeah, call
Get
Solari.
the help you need. We do
Yeah.
work very, very closely with one another.
Yep.
Spectrum, Polara, Taros, Solari, we stay in contact. We are also working behind the scenes to see
Yep.
what we can do to streamline processes, make things work better.
Yeah.
It's an ongoing process. So, you know, when in doubt, honestly, it's whatever number is at your fingertips. And
Call Solari.
yes, we'll work with you.
Yep, call Solari.
I
did,
absolutely agree, 100%. Call one of them. The best part about people who do this for a living is we will extend our hands over the line all the time. It happens. We will get crisis calls that are coming from Maricopa County, and I'm in Cottonwood, and I'm like, you know what? I'm doing everything I can within my ability right now to get this person the help they need. And to answer that question, call any of them.
I did text Bree to see if she would be able to get back on the line to discuss health choices situation in this matter. She had to hop off, but I'm going to put her contact information into the chat.
okay, thank you.
Well, actually, if there isn't if nobody has their hand up, I'm going to do mine, and unfortunately, mine has a long answer. So my son has a serious mental illness, and I discussed this topic with him, and this is his question: how can he believe when someone calls a crisis line, either he does or on his behalf, that he won't be locked up forever? And that's his concern. And that's his question. Well, nobody is brave enough to do it.
No, I'll take it. I'll take it.
Okay, Monica.
Okay.
So I am of the belief that transparency is king when it comes to crisis response. I lead with, I give you the rough stuff in the beginning, so I don't have to get bit in the rear end at the back end. So I keep full transparency during my calls. It is something that people worry about. I mean, not only for your son to pose this question for us, but for the calls that I respond to. People are very, very hesitant to share how they're actually feeling because they don't know where those spots are that mean A or B. So I can just speak to myself as a crisis response worker. I educate as I assess. So as I'm going through each element of the crisis evaluation and assessment, I'm saying, hey, we're going to do this next section that's talking about suicidal ideations. I want you to know that there are things that are very important in this, but plans, means, and intent. That's really where we're going to start to get into the meat and potatoes. And then I explain and normalize how just about every person on the planet has had either passive thoughts or active thoughts at some point in their life. Nobody rides for free. I educate while I assess. And that's something that as we train people in our department that I also teach them to do. It's scary. And to answer his question, I know it's a trust fall. And that element, hopefully with time will get better and that stigma will change, but that all comes through education and, you know, tossing the one starfish at a time into the ocean. That's where it's at.
Exactly right. Personally, I was able to witness an extremely serious crisis where the person coded. And the first responders and the crisis team came out. And that was my only experience in witnessing a crisis team. And that crisis team and the first responders were so respectful of the family, of the person that was being treated. It was absolutely wonderful. And are there problems with crisis responses? And a lot of it's education about what you should say, what you shouldn't say, or how it works. And I hope that this recording and this presentation will help in that. And for those of you who came on from other providers, please know that we do these programs month in advance, and we get speakers as we can. If you'd like to speak at a future meeting, Mental Health Monday, please contact NAMI Yavapai, and we will see how we can fit it in.
Thank you, guys. The speakers are great.
Thank you.